السلام عليكم.
وعليكم السلام.
وعليكم السلام ورحمة الله.
عليكم السلام ورحمة
وعليكم السلام دكتور هاني.
وعليكم السلام ورحمة الله.
وعليكم السلام دكتور هاني.
Okay, guys, today, inshallah, we will continue for the curriculum. We are in chapter 17. Inshallah, we are doing our best to finish early. And the question, I am doing my best to post more questions. So please study hard. And at least if you finish one chapter or two chapters or three chapters, at least go for the questions. If I did not cover any topic, try to search for this topic, try to search for PDF for any not covered topic, okay? Because as you know, it's difficult for me or for anyone who is doing sessions to cover every single 100%, okay? So at least we are doing our best to cover most of the conditions, most of the presentations, and most of the topics. If I did miss any topic or I did not cover any topic, so please don't skip this topic. All topics are important. So maybe you studied 10 topics in one chapter, they will ask you about the missed topic, okay? So please cover all. You should go for the exam with 100% preparation. Okay, so prepare yourself according to the curriculum and prepare yourself according to the blueprint. Again, the Royal College will ask you about the relevant basic sciences and epidemiology, differential diagnosis, investigation, and management of these conditions. And pediatric will be with the red color. It's very important. So 31 chapters from resus up to safeguarding and psychosocial emergencies in children. Resus we finished already, and we said you can study resus, very, very important. Trauma, very, very important. Also, trauma here, we are talking about major trauma and not major trauma, like orthopedic cases, dislocation or fracture. Number 3, cardiology. Number 3, cardiology. Number 4, pediatric. Number 5, sedation or anything related to anesthesia. So you have 5 important chapters to pass the exam. I'm talking about clinical questions. I did not talk about non-clinical questions. I'm talking about the clinical questions. So resus, trauma, cardiology, pediatric, and what else, guys? Anesthesia. Okay. So please, 5 chapters, very, very important. You have to cover them from A to Z. From A to Z, please. Okay. So resus finished already. Allergy, cardiology finished. Dermatology, NT, elderly care finished. Endocrinology, environmental, gastroenterology, hematology, infectious disease, maxillofacial and dental, mental health, musculoskeletal, neonatal, nephrology. And today, inshallah, we will cover neurology. So acute confusion. So this one already discussed in previous chapters. So the patient has confusion or unconscious, so confused or unconscious. Okay. And headache, you have to be familiar with types of headache. Seizures, status epilepticus, you have to be familiar with the algorithm for adult and pediatric. Speech disturbances, hemiparesis, hemiplegia, gait abnormality, visual disturbance, weakness, paralysis. Of course, here visual disturbance, it will be in ophthalmology, weakness, paralysis. So we are talking about speech, hemiparesis, gait, visual, weakness. We are talking about 5 criteria of Rosé score. So we are talking about stroke and TIA. Remember that 5 criteria: speech, hemiparesis or hemiplegia, gait abnormality, visual disturbance, weakness, paralysis. Dizziness, vertigo, already we discussed before in ENT. So be familiar with peripheral and central vertigo, how to diagnose and how to differentiate between peripheral and central vertigo from history, and how to differentiate from examination. So examination, as you remember, hence examination. Conditions here: botulism, cerebral venous sinus thrombosis, febrile convulsion. Each condition can be a scenario. Botulism can be a scenario, cerebral venous sinus thrombosis can be, febrile convulsion, Guillain-Barré syndrome we discussed before. So it's related to which system, guys? After which system infection?
gastroenteritis.
IT.
Rheumatoid GI.
Respiratory and GIT. Okay. So meningitis, encephalitis, and what is the difference between them? So meningitis most likely will be bacterial, encephalitis most likely will be viral, and here encephalitis, cerebral or CNS manifestation, and seizure may be focal neurological deficit as well. Multiple sclerosis, myasthenia gravis, Parkinson's disease, peripheral neuropathy, subarachnoid hemorrhage, stroke, TIA, tetanus, tumor involving the brain and the spinal cord, VB shunt, Wernicke's encephalopathy. So headache here, you have to be familiar with types of headache, how to diagnose them from the scenario, and what is the management for each one. So raised intracranial pressure, of course, here the patient has symptoms of or signs of raised intracranial pressure. So you will find whatever third cranial nerve palsy, or the patient has seizures or headache. The criteria or character of headache worsens with lowering the head, lying flat, coughing, or sneezing, can be associated with nausea, vomiting, and blurred vision. And of course, maybe pupillary changes. It's very important. And what is the management here, guys? Raised intracranial pressure.
Repeated
LP.
lumbar puncture.
Repeated LP. Acetazolamine.
Neuroprotective.
Ventilation.
So if the patient has hypotension or not, is this one benign or not? Okay. So if the patient has benign, it means there is no serious problem doing raised intracranial pressure. If the patient has serious problem like subarachnoid hemorrhage or anything, so you will use mannitol or you will use hypertonic sulfate. So subarachnoid hemorrhage here, sudden onset occipital or neck pain, worst ever headache, on exertion, vomiting, drowsiness, and the confusion may be present, as well as focal neurology. Meningitis in the scenario, neck or back rigidity, fever or photophobia. So these are the features. They can ask you what is the diagnosis, or the opposite, they can give you suspected subarachnoid hemorrhage what is the expected sign or feature in examination. So it can be by different way. Acute angle closure glaucoma, so unilateral and red, painful. So we will discuss about ophthalmology in its chapter about red eye and painful eye. Nausea, vomiting, also. Trigeminal neuralgia, unilateral shooting pain in face. Temporal arteritis, scalp, jaw pain, the age over 50, the scenario, fever, weight loss, or visual disturbance. Migraine, the patient has episodes, so he has previous episodes, unilateral or bilateral headaches, plus minus visual disturbance, and vomiting photophobia. Cluster headache, unilateral around an eye, conjunctival irritation, lacrimation, nasal congestion, eyelid swelling or dropping, facial sweating. So it can be a common headache and a benign headache. Cluster headache is benign. So it can be common question, unilateral around an eye, conjunctival irritation, ipsilateral. All features ipsilateral. Otherwise, it's wrong. So you should find ipsilateral. Ipsilateral conjunctival irritation, ipsilateral lacrimation, ipsilateral nasal congestion, ipsilateral eyelid swelling or dropping, ipsilateral facial sweating. Tension headache, so this one bilateral, or feeling of pressure. Procedures, so post-lumbar puncture. They will mention the patient has a lumbar puncture. After that, he has a headache. So what is the cause? This one, post-lumbar puncture. Postcoital cephalgia, whatever during or after sex. So this one, postcoital cephalgia. Medications, the patient, he has overuse of medication. Sinusitis, it's unlikely. This headache, unlikely in the exam. Medication overuse headache, patient is using multiple agents, often at low doses without effect on their headache. Combination agents containing barbiturates, codeine, caffeine. So if the patient is using these drugs, so the diagnosis here, medication overuse headache, can only be confirmed when symptoms improve after medication stop. So if the patient stop his medicine and the headache stop, so the diagnosis medication overuse headache. Migraine with aura will present with transient hemanopic disturbances. Migraine without aura needs to fulfill the International Headache Society criteria. So at least 5 attacks. Headache attacks lasting 4 to 72 hours. Headache has at least 2 of the following characteristics. So unilateral location, pulsating quality, moderate or severe pain intensity, aggravation by or causing avoidance of routine physical activity like walking, climbing stairs. Number 4, during a headache, one of the following: nausea or vomiting, phonophobia, not attributed to another disorder. So this is how to diagnose migraine. Medication overuse headache is suspected when patient is using multiple agents, as we said, often at low doses without effect on their headache. Combination agents containing barbiturate, codeine, caffeine. The diagnosis can only be confirmed when symptoms improve after medication is stopped. This history is classical for episodic tension type headache. Chronic tension type headache is by definition when headache occur on more than 15 days per month. So if the patient has headache more than 15 days per month, so this one chronic tension type headache. Idiopathic intracranial hypertension. So what is the diagnosis in the slide here? Fundoscope.
Papilledema.
Okay. So benign intracranial hypertension or pseudotumor cerebri most commonly occurs in overweight women. So if you find this a scenario, a woman and overweight, the age in the scenario 20 or 30, The clinical features, so worse in the morning, the patient has headache, worse in the morning and evening, relieved by standing, worse on lying down, aggravated by coughing, sneezing. Pain may also be experienced around shoulder girdle, nausea, vomiting, visual field deficit, sixth nerve palsy and diplopia. So here associated with sixth nerve palsy. Okay. Bilateral papilloedema, bilateral. So this one, both eyes. Investigations, so CT brain and or MRI and lumbar puncture. Always when you will do lumbar puncture, so first of all, do imaging. Okay, so any patient you are planning to do lumbar puncture, first of all, CT, then MRI, because maybe the patient has contraindication for lumbar puncture. So lumbar puncture here to measure the opening pressure and for CSF analysis. Treatment, prevent visual loss by one of the following. So repeated lumbar puncture to control intracranial pressure, medical treatment with acetazolamide, surgical decompression of the optic nerve sheath. So for you can use repeated lumbar puncture and medical treatment with acetazolamide. Cluster headache typically affect the men in their 20s. So the scenario will be 20 years, something like that. Male to female, 6 to 1, so most likely will be male. Smoking increase the risk developing cluster headache, so the patient may be smoker. The headache usually occur in cluster. He has this headache every 1 month or every year or every 2 years, something like that. Smoking also, headache usually occur in cluster, hence the name cluster, for a few weeks every year or 2. The pain is severe, unilateral, and often occurring around or behind the eye. It usually occurs at the same time each day and can cause the patient to become agitated, even so far as hitting their head against the wall. So they can mention in the scenario the patient is hitting his head against the wall or the floor to try and distract from the pain. So again, autonomic involvement. So ipsilateral conjunctival injection, ipsilateral rhinorrhea, ipsilateral lacrimation, ipsilateral meiosis. Standard analgesics are generally ineffective in the treatment of cluster headache. So it can be a question. Maybe they will mention clearly the patient diagnosed with cluster headache. What is the treatment? So it will be clear, or maybe they will give you features of cluster headache. They will not mention it's a cluster headache and they ask you what is the treatment. So the use of opioid in particular is not recommended. It can make the headache worse, so don't use opioid. Long-term use is associated with dependency. So no benefit from opioid and it has side effects dependent. Subcutaneous sumatriptan, 6 milligram is effective 10 to 15 minutes. So this is the option. Sumatriptan works by agonizing 5-HT receptor. Zolmitriptan nasal spray, so you can use sub-Q or you can use nasal. And also high flow oxygen. High flow oxygen here for 15 minutes. Octreotide administered sub-Q also can be an option. Temporal arteritis, we are talking about giant cell arteritis. So it's a chronic vasculitis characterized by granulomatous inflammation in the wall of medium and large arteries. So affect people over 50 years of age. You'll find the scenario more than 50. Clinical feature, we are talking about headache. So headache, scalp tenderness, jaw claudication. If you find that in the scenario, think about giant cell arteritis. Amaurosis fugax or sudden blindness. What does it mean, amaurosis fugax, guys?
It's a TIA. TIA.
Excellent. TIA. Yeah.
Mm.
So one of the criteria of stroke or TIA, neurological symptoms or signs or ocular. Okay, so neurological or ocular symptoms or signs, but TIA less than 24 hours and stroke more than 24 hours. A stroke, it's persistent, it's a constant, but TIA less than 24 hours and transient. Okay, so here it's a visual disturbance and it's transient, less than 24 hours. Or sudden blindness, usually unilateral. So if they mention the patient more than 50, for example, 60 years, he has headache, he has scalp tenderness when he is combing his hair, he has jaw claudication when he's brushing his teeth, and he has a vision problem for 1 hour or 2 hours or whatever. So think about temporal arteritis or giant cell arteritis associated with polymyalgia rheumatica. So if they mention that in the scenario, so think about temporal arteritis or giant cell arteritis. In 50% of cases, bilateral upper limb stiffness, aching and tenderness, pelvic girdle pain. Visual loss occurs early in the course of the disease and once established, rarely improves. You will find raised ESR in the scenario. Early treatment with high dose corticosteroid. So remember that. High dose corticosteroids, not analgesia here. So high dose corticosteroid. Prevent further visual loss and other ischemic complications. If giant cell arteritis is suspected, high dose glucocorticoid treatment should be initiated immediately. 40 to 60 milligram prednisolone daily. Urgent referral for a specialist evaluation, same day. So if you find option for same day, 2 weeks, 1 month, so choose same day ophthalmology assessment for those with visual symptoms, and the temporal artery biopsy should be organized. Status epilepticus. So here continuous seizure activity for 5 minutes or more without return of consciousness. So if the patient has continuous seizure more than 5 minutes and the patient did not gain his consciousness, so we are talking about a status epilepticus. Or recurrent seizures, 2 or more without an intervening period of neurological recovery. Emergency investigation, as you know, blood gases, glucose, renal liver function, calcium, magnesium, full blood count, blood clotting, toxicology screen, chest radiograph to evaluate possibility of aspiration, brain imaging, lumbar puncture. So first, you should exclude any contraindication by brain imaging and then lumbar puncture. So this one, within 5 minutes or after 5 minutes investigations?
After 5.
After 5 minutes or within 5 minutes?
Within 5 minutes.
Within, okay. So don't start the treatment until 5 minutes passed. So in the first 5 minutes, you will assess the patient, A, B, C. You will extract the blood where A, B, or C?
C.
See.
C. So in first 5 minutes, okay, from 0 to 5 minutes, so you will assess the patient, A, protect the A. So intervention, patient needs intervention in A, do intervention. Doesn't need, go for B, breathing. Needs intervention, do. Doesn't, go for C, extract the blood. Needs intervention? Do. And here, blood sugar where? In A, B, C, D, or E, or before A?
Before A.
Before A. Before A. Before A.
Before A or in D?
D.
In D. In D, guys. Okay. So, what are the causes of seizure? Number one is
Hypoglycemia.
hypoxia. The first killer is
Hypoxia.
airway. The first killer is airway. Okay. The second killer is breathing. The third killer is
Circulation.
circulation. The fourth killer is disability. Okay. So here, hypoxia, the first cause of seizures. Any patient with hypoxia, he will get seizure. Okay. So hypoxia here may be because of airway compromise and because of breathing compromise, right? How?
Yes.
If the patient has loss of airway reflexes and he has compromised the airway, so he has hypoxia, so he has seizures. If the patient has patent airway and he has breathing compromise, like he has apnea or respiratory rate, for example, 4, he will get hypoxia or not?
Yes.
Yeah, of course.
Okay, so I want you guys to think logically. Always be organized. Everything will be smooth with you. Okay, so here in breathing, compromise, hypoxia, seizures. Even the airway is patent. So here, blood sugar in D. So what is the benefit? If you will ask the nurse to check oxygen saturation, she said oxygen saturation is 70. And you ask her to check blood sugar, she said blood sugar is 1 millimole. So the patient has hypoglycemia and he has hypoglycemia. Which one you will manage first?
Hypoxia.
Hypoxia.
So what is the benefit of you will check blood sugar? Clear? You have to manage airway first. Okay, so always the patient can die from hypoxia, but he cannot die from hypoglycemia. Remember that. Okay, even any patient with hypoglycemia, he will not die. Don't worry. Okay, we find all patients with blood sugar is 20 milligram or like 1 millimole. Okay, and still alive. He did not arrest at all. Okay, once you give him blood sugar, conscious, alert. Okay, but hypoxia, I found many patients died from hypoxia. Many patients arrested from hypoxia. So please, blood sugar here in disability. Okay, so monitoring is as follows: regular neurological observation and measurements of blood pressure, temperature, ECG, biochemistry, blood gases, clotting, blood count, drug levels. Patients require the full range of ICU facilities, and the care should be shared between anesthetist and neurologists.
Sorry, Dr. Hani.
Yes.
What do you mean by monitoring now? Monitoring after he recovered from status epilepticus, or because this is monitoring?
Yes, monitoring here, it means regular. Okay. Already you manage the patient. Already.
After managing, yes.
Yeah. After you manage the patient, after you finish ABCD approach. Okay. Between mild seizures, we are talking about child. So absence seizures in the scenario, how to diagnose that? Absence seizures, type of primary generalized epilepsy that is most commonly seen in children. The hallmark of the absence seizures is abrupt, sudden onset impairment of consciousness interruption of ongoing activities, blank stare, and sometimes brief upward rotation of the eyes. So if you find that in the scenario, you can diagnose petit mal seizures. AEG cannot confirm or disprove a diagnosis of epilepsy, but instead form part of context diagnosis. Typically show generalized 3 to 4 Hertz spike and slow wave complexes. So it's difficult to find that in the scenario, but at least you will find absence seizures and the age is child. Okay, you will find the onset in the scenario. Okay, maybe you will find upward rotation of the eyes, brief. Okay. What about the algorithm? So step 1, 5 minutes after start of convulsion. So you will give lorazepam. We said 5 minutes after. It means 0 to 5, done. ABCD approach, done. Now from 5 to 10 minutes. Okay, so lorazepam 0.1 milligram per kilogram IV or IO if vascular access is available. Buccal midazolam 0.5 milligram per kilogram or rectal diazepam 0.5 milligram per kilogram. Okay, if no vascular access is available. So check the scenario. If you find in the scenario IV access, it shows lorazepam IP. If no access, so it shows rectal diazepam or buccal midazolam. Even if the patient has convulsions and he cannot open his airway, can you use buccal midazolam?
No.
Why no? Buccal here, it means between the cheek and the teeth. So you can use, right? Okay. You will not insert in the mouth, no. Between the teeth and the cheek, right?
Okay.
So you can use. Step 2, 10 minutes after start of step 1. So if the patient is still after lorazepam or midazolam or diazepam for 10 minutes, still seizing, so you will use benzodiazepine and here senior help. Step 3, 10 minutes after start of step 2. At this stage, senior help is needed to reassess the child and advise on management. If not already on phenytoin, then phenytoin infusion, 20 milligram per kilogram IV infusion over 20. Sometimes they will mention 18, sometimes 20, sometimes 18 to 20. So anyway, if you find any of them in the scenario, you can choose. But the most important, the patient is not allergic to phenytoin. The patient is not using phenytoin. The patient not given phenytoin. So this is the indication to give phenytoin. So if the ambulance did not give phenytoin, or the patient is not allergic to phenytoin, or the patient is not epileptic, he has no history of epilepsy and he is not using phenytoin, so you will give phenytoin. If you did not find 3 options in the scenario, so you can choose. What if the patient in the scenario has epilepsy and already received phenytoin in the morning? So what you will give?
Phenobarbital.
If the patient has allergy for phenytoin, what you will give?
Phenobarbital.
If the ambulance crew give phenytoin and they're not responding, what you will give?
Phenobarbital.
Okay, so you have 3 points to think about them in the scenario. Rectal baraldehyde can be considered at a dose of 0.8 ml per kilogram, 50-50 mixture, while preparing the infusion. So you are preparing for a rapid sequence induction, and also you are preparing for whatever phenytoin or phenobarbital. In the meanwhile, you will give rectal baraldehyde. So already in step 3, you will prepare for infusion, you will prepare for rapid sequence induction, and in the meanwhile, you can give rectal baraldehyde.
But Hannah, I have a question. Sorry.
Yeah.
We will give phenytoin and phenobarb both
No,
or one of them.
one of them. Again, phenytoin indication if the patient is not using phenytoin. It means he has no epilepsy, no history of epilepsy, okay? Because if he has a history of epilepsy, it means he's using phenytoin. Or at least, most likely, he's using phenytoin. Number two, the ambulance crew did not give phenytoin. Number three, he has no allergy of phenytoin. They did not mention clearly in the scenario, the patient has documented allergy to phenytoin. Okay.
I mean, Dr. Hani, if he receives phenytoin and not respond, we will go to RSI or give after that phenobarb.
Phenobarb.
If not respond, we will give phenobarb.
Yes, yes.
Okay.
Yeah.
Thank you.
So here, step 4, it's unlikely to ask you in the exam like that. So in the exam, they will give you option for rapid sequence induction. So you can go directly for rapid sequence induction, okay? So step 4, 20 minutes after start of step 3, if the child is still seizing, so the anesthetist must be present and rapid sequence induction with thiopental. What about adult? So first stage, early status, 0 to 10 minutes, 10 minutes. So again, you will secure airway, ABCDE, within 10 minutes. In pediatric, within how many minutes?
5 minutes.
Here
5
they
minutes.
said within 10 minutes. So secure airway, resuscitate, administer oxygen, assess cardiorespiratory function, establish IV access. So it means airway, breathing, circulation, disability exposure. Second stage, 0 to 30 minutes, institute regular monitoring, consider the possibility of non-epileptic status, commence emergency anti-epileptic drug therapy, emergency investigation, administer glucose and or intravenous thiamine as Babrenix if any such suspicion or suggestion of alcohol abuse or impaired nutrition. Treat acidosis if severe. Third stage, 0 to 60 minutes, establish etiology, alert anesthetist and ITU, identify and treat medical complications, pressure therapy when appropriate. Fourth stage, 30 to 90 minutes, transfer to ICU, establish ICU care, EEG monitoring, initiate intracranial pressure monitoring where appropriate, initial long-term maintenance AED therapy. So pre-hospital, it's not our duty. So the patient will take diazepam, 10 to 20 milligram given rectally, repeated once 15 minutes, later if status continues to threaten, or midazolam 10 milligram given buccally. If seizure continue, treat as below. Early status, so lorazepam as pediatric, 0.1 milligram per kilogram, usually 4 milligram bolus. Repeated once after 10 to 20 minutes. Give usual AED medication if already on treatment. For sustained control or if seizures continue, treat as below. Establish the status, so phenytoin infusion, 15 to 18 milligram per kilogram. So as I said before, if you find 15 to 18 or 18 or 18 to 20 or 20, both accepted at a rate of 50 milligram per minute, or phosphonitoin infusion at those same dose and the same rate. Phenobarbital bolus, as you see here, guys, and or, okay? Clear here? And or phenobarbital bolus, 10 to 15 milligram at a rate of 100 milligram per minute. Refractory status, general anesthesia with propofol. In pediatric, you will use what?
Thiopental sodium.
Thiopental, but in adult, yeah, propofol, midazolam, thiopental sodium. Of course, you will not use all, but what if you give propofol and still seizing? You can use midazolam, still seizing, you can use thiopental and so on, okay? So here, it's an on and or, and or. So propofol 1 to 2 milligram per kilogram bolus, then 2 to 10 milligram per kilogram per hour. So this one infusion titration. Midazolam 0.1 up to 0.2 milligram per kilogram bolus. Then infusion. Cyclothal sodium 3 to 5 milligram per kilogram bolus. Then infusion. Anesthetic continued for 12 to 24 hours after the last clinical or electrographic seizure, then dose taper. So weakness and paralysis. This can be scenario in the exam, motor neuron disease, cluster of major degenerative disease. So here from the brain to the muscle, motor neuron disease. So selective loss of neurons in the motor cortex, so in the brain, cranial nerve nuclei, anterior horn cells. Okay, so also from the brain to the spinal cord. So the lesion here. Both upper and lower motor neuron are affected. No sensory or sphincter disturbance. So this one intact. Sensory or sphincter disturbance, it's intact. And eye movement are not affected. So how to diagnose in the exam? They will mention the patient has any feature for motor cortex, cranial nerve nuclei, and anterior horn cells, but they will not mention any abnormality in sensation or sphincter disturbance or eye movement. So it's easy to diagnose motor neuron disease. Relatively uncommon, prevalence is 5 to 7 per 100,000. So it's very rare. Median age at onset 60 years in the UK, and often fatal within 2 to 4 years of diagnosis. It's a serious. Any patient with motor neuron disease expected fatal within 2 to 4 years. So 60 years in the scenario, and again, sensation, sphincter, it's intact, eye movement intact. Motor neuron disease, 4 distinct clinical pattern. So the first one, amyotrophic lateral sclerosis, ALS, progressive bulbar palsy, progressive muscular atrophy, primary lateral sclerosis. Amyotrophic lateral sclerosis, this one type from motor neuron disease, it's 50% of all motor neuron disease. So it's a common. Loss of motor neurons in both motor cortex and the anterior horn of the spinal cord. Clinically, there is weakness in both upper and the lower motor neuron signs. Okay. So what about sensation, guys? Intact. And sphincter disturbance, not
autonomic and ocular or intact.
and eye movement not affected. Okay. So here, loss of motor neuron in both motor cortex, anterior horn of the spinal cord, it's 50%, and the patient has weakness in both upper lower motor neuron. Progressive bulbar palsy, this one 10%. This condition affects the cranial nerves 9 and 12. Okay, so bulbar and pseudobulbar palsy. So if you find the same features of motor neuron disease and you diagnosed already motor neuron disease, and you find additional feature for cranial nerve 9-12 palsy, so this progressive bulbar palsy. Progressive muscular atrophy, it's 10%. This condition affects the anterior horn cells, and therefore only lower motor neuron signs encountered, only lower motor neuron signs. Primary lateral sclerosis, loss of Betz cells in the motor cortex, upper motor neuron signs, and marked spastic leg weakness and pseudobulbar palsy. So if you find marked spastic leg weakness in the scenario, pseudobulbar palsy, So it's a primary lateral sclerosis. And the diagnosis also is motor neuron disease. Dizziness and vertigo we discussed before. You have types of dizziness, maybe vertigo. So vertigo is type of dizziness. Okay. So vertigo, strong sense of motion or spinning, disequilibrium, feeling of balance. The patient is feeling of balance or unsteady, lightheadedness, racing cope. So one of the types of dizziness vertigo, as we said, peripheral vertigo and central vertigo. We discussed in previous chapter in ENT. You can review that. So peripheral here, sudden onset in the scenario. Central, it will be gradual. Intermittent with severe symptoms, peripheral. Affected by head position and the movement, so peripheral. Nausea, vomiting, frequent and severe here in peripheral. So if the patient has severe nausea, the patient has severe vomiting, and the patient is feeling he will die, you should be happy, okay, because it's peripheral. But if the patient has no nausea or vomiting and the patient is calm, you should be worried. If the patient is not afraid of dizziness, should be worried, okay. Motor function, gait and coordination typically intact, because we are talking about peripheral, but here in central will be motor function, gait, instability, loss of coordination frequent. So neurological symptoms and signs. Botulism, so Clostridium botulinum is large gram positive anaerobic bacillus. So this one, it can be common question, botulism. Presence as descending paralysis anticholinergic syndrome. So what about Guillain-Barré syndrome, guys? Descending or ascending?
Ascending.
Descending paralysis.
Descending.
So botulism, yeah, botulism.
Descending.
No,
Opposite.
but botulism descending, but
Descending. Oh, yes.
it's ascending.
Yes.
Okay, autonomic dysfunction with orthostatic hypotension is common. Alias urinary retention may occur. Antitoxin, intensive care unit admission, early intubation are often indicated. So the management, as we said before, 50% of the exam or maybe 70% of the exam management. So here, antitoxin, intensive care unit admission, early intubation. Okay, early intubation, even the patient doesn't need intubation, you will intubate. Like the patient has anaphylaxis, he's breathing now, but you should do early intubation. The patient has burn, he can breathe now, and the airway is patent now, but you should intubate. So it's early intubation, elective intubation, not emergency intubation. So remember that, botulism, early intubation. Risk factors. So the most important, how to diagnose. They will mention the patient has paralysis and he has symptoms of anticholinergic syndrome and started from up to down. And here, alias urinary retention can be there. Risk factors, they will mention in the scenario the patient ingested contaminated food, ingested honey or soil in infants, contact with reptiles, intravenous drug use, crash injury, abnormal bowel anatomy, therapeutic or cosmetic use of botulinum toxin. Cerebral venous sinus thrombosis. So here, headache is the most frequent symptom and is typically characterized by severe head pain that worsens with Valsalva maneuver and with recompense. Headache onset, usually gradual, increasing over several days. However, some patients with cerebral venous sinus thrombosis have sudden explosive onset of severe head pain, so it's thunderclap headache that mimics subarachnoid hemorrhage. What does it mean, thunderclap headache?
Subarachnoid. Subarachnoid.
Rapid
It's
within 5
severe
minutes.
Excellent.
Less than 5 minutes. Less than 5.
Within 5 minutes, the headache reach its maximum intensity within 5 minutes. Okay, so the patient has severe headache. You will ask, when did that start? You would say 4 minutes, 3 minutes, 2 minutes. Okay, that's why he went to hospital very early. Okay, so it's called central headache. And this one, you should exclude subarachnoid hemorrhage first. Symptoms and signs of cerebral venous sinus thrombosis can be grouped into 3 major syndromes. Maybe isolated intracranial hypertension syndrome, focal syndrome, cephalopathy. So isolated intracranial hypertension syndrome, headache with or without vomiting, papilloedema, visual problems. So already you diagnose it's a cerebral venous thrombosis, cerebral venous sinus thrombosis, and you find the patient has headache with or without vomiting, papilloedema, visual problem. Think about isolated intracranial hypertension syndrome. The patient has focal deficits like weakness with monoparesis or hemiparesis, or aphasia, seizures, or both. Think about focal syndrome. The patient has multifocal signs, mental status changes, stupor or coma, so think about cephalopathy. Antiplatelet agents may be considered if absolute contraindication to anticoagulation exists. So if the patient has contraindication to anticoagulant, use antiplatelet. But the first line is anticoagulation. Isolated thrombosis of the different sinuses and the veins produce diverse clinical pictures. For example, in cavernous sinus thrombosis, ocular signs dominate the clinical picture with orbital pain, chemosis, proptosis, oculomotor pulses. Febrile convulsion, it's a pediatric, red color. Benign generalized convulsions occurring in otherwise normal children who are febrile, secondary to an extracranial infection. So the infection here, extracranial, not brain infection. Diagnostically, they must occur in developmentally normal child, last for less than 20 minutes. Be generalized with no complex features and leave no residual abnormality. So you have to be familiar with complex febrile convulsion, how to understand its normal febrile convulsion, how to understand its complex febrile convulsion. So if you find in the scenario the patient has focal seizure, it's a complex. If you find the seizure more than 15 minutes, it's a complex. If you find more than one convulsion, so it's complex. Child being left with focal neurological deficit, so complex. It means after he gained his consciousness, he still have focal deficit. For example, the patient cannot walk or the patient cannot move his arm or leg. So it means it's a complex febrile convulsion. Otherwise, it's normal febrile convulsion, okay? Generalized, benign generalized. So the prognosis of febrile convulsion is good. 30 to 50% risk of recurrent febrile convulsions. So even in OSCE exam, guys, they can give you scenario for febrile convulsion. And the patient, you start to give him, after 5 minutes, you start to give him diazepam, and then 10 minutes, you give him diazepam, and then phenobarbital, and then, so this good prognosis or bad prognosis?
This is bad prognosis.
Bad prognosis, okay. Yeah, so here we are talking about complex febrile convulsion because more than 15 minutes, okay. So 30 to 50% risk of recurrent febrile convulsion, 10% risk of recurrence within the first 24 hours, the risk of long-term epilepsy about 60. Actually, this is different from source to source. Guillain-Barré syndrome, so initial symptoms, a change in sensation of pain or pain, along with muscle weakness, beginning in the hands and or feet. That's why it's ascending. This often spread to the arms, upper body, with both sides being involved. This disorder is potentially life-threatening in the acute phase, with approximately 15% of patients developing weakness of the muscles of respiration and requiring mechanical ventilation. The exact cause is unknown, but the underlying mechanism is thought to involve autoimmune disorder, which is the body's immune system attacks the myelin sheath surrounding the peripheral nerves. 75% of cases have history of preceding infection, 75%. Most commonly gastrointestinal or respiratory. And what is the causative organism?
Factor.
Yes. So followed by episthemovirus virus, it's one of the common also. Cytomegalovirus, mycoplasma pneumonia. But the most common Campylobacter.
Campylobacter, yes.
The symptoms of Guillain-Barré syndrome usually reach their peak at around 4 weeks and then gradually improve. So the patient has Guillain-Barré syndrome, he has muscle weakness. And this muscle weakness can affect the hands, the feet, the chest. That's why the patient needs mechanical ventilation. And this will persist for how many weeks?
4 weeks.
4 weeks, yeah.
It's better to be familiar with that. Why? Because this patient may need admission for a few weeks, okay? After that, he will improve. Diagnosis, clinical examination, confirming areflexia, progressive weakness in the legs and of an arm, nerve conduction studies, lumbar puncture. So it can be a question. So what is the investigation of a choice here? Lumbar puncture. And what is the finding? Can be a question. High protein with few white blood cells. Okay, remember that, please. Treatment, supportive. It means if the patient needs oxygen, give oxygen. Patient needs intubation, ventilation, do. If the patient needs a fluid, do. And here, immunoglobulin are often utilized to shorten the duration. It will not treat, but it will shorten the duration of the plasma exchange. Remember that it can be option in the exam. You can choose ventilatory support in the acute phase and the nasogastric feeding. So remember this treatment. Miller-Fisher syndrome, it's a variant of Guillain-Barré syndrome. So if you diagnose the patient has Guillain-Barré syndrome and you find this triad, ataxia, reflexia of psalmoplegia, so you will diagnose Miller-Fisher syndrome. Meningitis encephalitis, I think we are familiar with that. Meningococcal disease suggested by presence of non-blanching rash, we discussed before, particularly if any of the following features are present and ill-looking. Lesions more than 2 mm in diameter, so purpura. Capillary refill time more than 3 seconds or longer. Neck stiffness. Bacterial meningitis is suggested by the following symptoms. So neck stiffness, bulging fontanelle if child, decreased level of consciousness, convulsive status, epileptics. In the UK, most cases of meningococcal septicemia are caused by Neisseria meningitis group B. The vaccination program for Neisseria meningitis group C has made this type much less common. Vaccine for group B is being tested in clinical trials, but is not yet available for general use. So now we talk about bacterial meningitis. What about encephalitis? So you will find focal seizures focal neurological signs, focal seizure decreased GSS. So you have 3. Focal neurological signs, focal seizures, decreased GSS. So think about herpes simplex encephalitis. Okay. Life-threatening disease, treatment should not wait for laboratory confirmation, and antibiotics should be started immediately. So any patient with meningitis or encephalitis, you will take blood culture, you will take lumbar puncture, and you will give antibiotic if suspected meningitis. You will give antibiotic plus also antiviral if suspected encephalitis. So pre-hospital setting, it's not our duty, but be familiar with that. IM benzyl penicillin. Hospital setting, so IV ceftriaxone, 2 grams for adult, and pediatric 80 milligram per kilogram. IV cefotaxime, 2 grams for adult, 80 milligram for child. Chloramphenicol is suitable alternative if there is history of anaphylaxis or allergy to cephalosporin. What about chemoprophylaxis? So chemoprophylaxis here, people who are in contact with patients with meningitis. So what is the chemoprophylaxis for them? Rifampicin, 600 milligram BO, BD for 2 days. Again, people who are in contact with patients with meningitis, you can give them rifampicin, 600 milligram BOPD for 2 days. Single oral dose of ciprofloxacin, 500 milligram may also be given. Rifampicin, ciprofloxacin are both contraindicated in pregnancy. Remember that. Single 250 milligram dose of IM ceftriaxone. So if the patient pregnant, don't give rifampicin or ciprofloxacin. Multiple sclerosis, so demyelination of nerve cells within the brain and spinal cord. Cell-mediated autoimmune disease caused by recurring inflammation. It can present in early adulthood, female to male 3-2, so maybe the scenario female. Risk factors, Caucasian race, distance from the equator. Generally speaking, the further from the equator, the higher the risk. Family history, so 20% of multiple sclerosis patients will have affected relative. Smoking, so the ethnicity and also the country and also family and the smoking. The rates of relapse appear to fall during pregnancy. So you have 3 main patterns of multiple sclerosis, maybe relapsing and remitting, from the name relapsing and remitting, multiple sclerosis, primary progressive multiple sclerosis, secondary progressive multiple sclerosis. So relapsing and remitting, this one asymptomatic period followed by relapses. So the patient has already multiple sclerosis, but sometimes he has no symptoms, and then sometimes he has symptoms. Okay, so it's called relapsing and remitting. What about primary progressive multiple sclerosis? Symptoms from the outset develop and worsen with few remissions. Secondary progressive multiple sclerosis, this follows on from relapsing remitting multiple sclerosis. There are worsening symptoms with fewer remission. 50% of those with relapsing remitting will go on to develop this within 10 years of diagnosis. So if they mention the patient has multiple sclerosis 10 years back and he has symptoms now, so this one secondary. Okay. If the patient has symptoms not disappearing, so this one primary. The patient has symptoms and then disappear, then appear. So this one relapsing and remitting. Good prognostic factors if the patient has relapsing remitting course. So the first one, this good prognosis. Female sex, so this one is good prognosis. Presence of sensory symptoms, this good prognosis. And early age at onset, so good prognosis. The key in diagnosis of multiple sclerosis is the history of neurological symptoms that are discrete in time and location of the body affected, fatigue, low mood, particularly during a relapse. Parkinson's disease and other movement disorder. So this is the normal, this is the Parkinson's disease. So as we see here, substantia nigra, this one, it's very big, this is the normal. And if atrophy like that, so this Parkinson's disease. Okay, so this one, substantia nigra, this one. So the problem in this area. Parkinson's disease characterized by rigidity, hypokinesia, bradykinesia, wrist tremor. So what does it mean? Rigidity, as you know, increased tone and cogwheel rigidity. Hypokinesia, poverty of movement. Bradykinesia, slowness of movement. Wrist tremor, typically 4 to 6 cycles per second. Other commonly encountered clinical features, like the patient has in the scenario, gait disturbance, or maybe they will mention shuffling gait with loss of arm swing, loss of facial expression, monotonous, slurred speech, microgravia, small cramped handwriting, increased salivation, dribbling, difficulty with fine movements. So think about Parkinson's disease. The signs are generally unilateral. Remember that, unilateral, at the time of diagnosis, but are progressive and may become bilateral as the disease progresses. So if the patient has these symptoms and he has unilateral, this in early stage or late stage?
Early stage.
Early stage. And if the patient has these symptoms or features and he has bilateral, so it's a late stage. So how to understand it's later stages or not with the disease? So additional clinical feature may become apparent. So if you find in the scenario the patient has postural instability, it's a late stage. Cognitive impairment is the late stage. Orthostatic hypotension, so it's a late stage. Depression and dementia, it's a late stage. Autonomic disturbance and pain, so late stage. If you find any of these features, so late stage. Parkinson's disease treatment, you will use copinildoba, so combination of levodopa and enserazide. Side effects can cause nausea, dizziness, sleepiness, dyskinesia, mood changes, confusion, hallucination, and delusions. Types of Parkinson's disease. Think about idiopathic Parkinson's disease, this one, IPD, idiopathic Parkinson's disease, MSA, multiple system atrophy, BSP, progressive supranuclear palsy, CBD, corticobasal degeneration, DLP, we discussed that before, dementia with Lewy bodies. So how to differentiate between them? Already, you know how to diagnose Parkinson's disease. So you find in the scenario, rigidity, hypokinesia, bradykinesia, wrist tremor, and all these features. And if unilateral, it's early. If bilateral, it's late. If you find these features, it's late. And how to differentiate the types of Parkinson's. So if you find one side of the body affected more than the other, So it's a bilateral or unilateral?
Bilateral.
Bilateral, but one side more than the other. So
Other
it's
side.
called idiopathic Parkinson disease. Okay. If you find both sides equally affected, so multiple system atrophy. If you find both sides equally affected, so also it can be progressive supranuclear palsy. If you find one side of the body affected more than the other, so it can be corticobasal degeneration. If you find both sides equally affected, so dementia with low bodies. So if you find bilateral, think about MSA, PSP,
PSP,
DLP.
DLP.
Yeah, 3. 1, 2, 3. If you find bilateral but one more than the other, think about idiopathic or corticobasal.
Corticobasal.
Okay. Okay. What about tremor? An idiopathic typically starts at rest on one side of the body. Typically start on the rest, at rest on one side of the body. Regarding multiple system atrophy, not common, but may occur. So tremor here, if you find the tremor, it means it's unlikely to be multiple system atrophy because they said not common. And progressive supranuclear palsy, so less common, if present, affect both sides. So here it's less common. If you find the tremor, it will be in both sides. And corticobasal degeneration, not common. And they'll be not common. So anyway, if you find the tremor, most likely will be
Idiopathic or
yes,
progressive supranuclear.
idiopathic only. So typically start at rest.
Unilateral.
Yeah, typically. So if you find the patient has tremor, think about idiopathic. What about treatment? Levodopa response. In idiopathic, it's excellent response. So once you give the patient levodopa and he's responding. So what does it mean?
Idiopathic.
Yes. If you find the minimal, so it can be other causes or other types. So minimal response. Okay. So idiopathic here, it's with tremor and excellent response to levodopa. Yeah. What about mental changes? So idiopathic depression and multiple system atrophy depression and corticobasal degeneration depression, DLB, there is nothing.
No mental change.
No mental change. So what about progressive supranuclear degeneration, supranuclear palsy? So personality changes, depression, both. So if you find in the scenario, the patient has personality changes and the depression, so it's a progressive supranuclear palsy. What about balance and fall? Okay, so if the patient has a loss of balance or fall late in the disease, okay, so it's idiopathic. Within 1 to 3 years, it's multiple system atrophy. Within 1 year, so it's progressive supranuclear palsy. Within 1 to 3 years, What about common eye abnormalities? In idiopathic, dry eyes, trouble focusing. In MSA, dry eyes, trouble focusing. In BSP, dry eyes, difficulty in looking downwards. In CBD, dry eyes, trouble focusing. In DLB, dry eyes, trouble focusing. Anyway, if you will listen to this video, you can review again. The Parkinson plus syndromes are a group of neurodegenerative disorder. What does it mean? So the patient has Parkinson, for example, 1 or 2 or 3 years. After that, he has additional features. Okay, so why we are discussing this slide. So it means the patient has Parkinson's disease and other movement disorder. It means the patient has Parkinson's disease, for example, 3 years ago. After that, he has additional features. According to these features, you can diagnose the additional type of Parkinson. So it's called Parkinson plus syndromes. So it's a group of neurodegenerative disorders featuring the classical features of Parkinson's disease with additional clinical features that distinguish them from idiopathic Parkinson's disease. Okay. So idiopathic here, this is the original Parkinson's disease. Otherwise, the patient has additional symptoms. It means maybe multiple system atrophy, as we discussed, maybe progressive supranuclear palsy, maybe corticobasal degeneration, dementia with low bodies. Regarding multiple system atrophy, results from loss of cells in multiple different areas of nervous system. Much less common than idiopathic Parkinson's disease and less common than progressive supranuclear palsy. Multiple system atrophy progress rapidly, resulting in people being wheelchair around 3 to 4 years from the time of diagnosis. The distinguishing features of multiple system atrophy, so the development of autonomic dysfunction, bladder control problems, erectile dysfunction, blood pressure change and associated symptoms, early onset balance problems, neck or facial dystonia, high-pitched voice. So if you find any of these features, think about multiple system atrophy. Okay, condition number 10, peripheral neuropathy. So think about nerves. We are talking about peripheral. Think about nerves in the peripheral. So median nerve injury, ulnar nerve injury, radial nerve injury, and herpes palsy, clump palsy. So here we are talking about brachial plexus, means the roots C5, C6, C7, C8, and T1. Okay. So median here coming from C5 and from C8 and T1, and ulnar, so it's coming from C8, T1, and regarding radial, it's coming from C5 and C7 and also C8, T1. So here, regarding herpes palsy, what's your roots guide? Up or down?
Upper root. Upper.
Yeah, upper. Okay. So herpes palsy, it's from upper roots, C5, C6, and the clump palsy, so it's a C8, T1. So ulnar nerve, you should be familiar with the normal pathway. And after that, you will understand the injury, the pathophysiology. So the ulnar nerve originates from medial cord. We are talking about ulnar. Ulnar means the medial side. So it means medial cord of brachial plexus originating from C8 to T1. C8 to T1. Ulnar is this one. Okay. Motor function and the sensory function. So we will discuss motor and the sensory. Motor innervates the muscles of the hand apart from senar muscle. So ulnar here will cover all muscles of the hand except senar muscles. Senar muscles will be covered by or supplied by
Median nerve.
Okay, and the lateral two lumbricals, supplied by also median nerve. So again, the ulnar nerve will cover or supply all hand muscles except senar muscles and lateral two lumbricals. So here, if the patient has wasting of senar muscles and the lumbricals, what is the reason?
Median nerve.
Injury.
Medial nerve injury.
Yes, any patient with wasting, muscle wasting, because nerve injury, because he is not moving these muscles. That's why wasting, okay? Two muscles in the anterior forearm, flexor carpi ulnaris, because we are talking about ulnar nerve, so it's covering flexor carpi ulnaris and the medial half of flexor digitorum profundus. So finish the motor. What about sensory? Innervates anterior and posterior surface of medial. We are talking about ulnar, so medial side. Anterior and posterior surface of medial 1.5 fingers and associated palm and dorsal hand area. Okay, so medial 1.5 digits. What about 3.5 digits lateral?
Median.
Median.
Radial posterior.
Median.
Yes. So think about palmar of the hand and dorsal of the hand, median and ulnar in the palmar side, and radial in dorsal side.
Dorsal side.
There are 3 sensory branches of ulnar nerve. 3, we are talking about sensory now. 3 sensory branches of ulnar nerve that are responsible for its continuous innervation. Why we are studying that? To understand this patient has ulnar nerve injury where? In the forearm or in the wrist? Okay, in the forearm or in the wrist. So 2 of these arise in the forearm and travel into the hand. So palmar cutaneous branch, dorsal cutaneous branch, which innervates the skin of medial half of the palm, dorsal cutaneous branch, which innervates the dorsal skin of the medial one, and half finger associated dorsal hand. The third branch arises in the hand. So 2 branches, palmar and dorsal, in the forearm. And the third branch, it's a superficial branch, innervate palmar surface of medial 1.5 fingers. What about damage? So motor and the sensory. It will affect the motor function and the sensory function. So regarding the motor, damage of ulnar nerve at elbow and the wrist can be distinguished by the fact that the 2 muscles, the ulnar nerve innervate in the anterior forearm, as we said, it can cover flexor carpi ulnaris and the medial half of flexor digitorum profundus will be spared if it is injured in the wrist. Okay, so injury in the proximal, it will affect it, in the distal, it will affect the proximal or not?
Yes.
No.
Yes.
It will affect this.
I will explain by different way. I'm talking in general now. For example, the patient has problem in the brain. Brain here is proximal or distal?
Proximal.
Proximal. And the patient has problem in his hand. It's distal or proximal?
Distal.
Distal. So if the patient has injury in his brain, it will affect the brain and the hand, right?
Yes.
If the patient has injury in the hand, it will affect the brain?
No.
It will
No.
spare proximal,
Yes.
right? Okay, so the forearm and the wrist, which one is proximal, which one is distal?
Forearm.
It's proximal.
And this
proximal.
is distal. Okay, so if the patient has injury in the wrist, the muscles in the forearm will be spared, right?
Yes.
Yes. So here, if you find the patient has a sparing, it means normal flexor carpi ulnaris and the normal medial half of flexor digitorum profundus, it means the injury at wrist. I think it's clear now. When the ulnar nerve is damaged at the elbow, so the injury here proximal or distal? Proximal. Okay. So when the ulnar nerve is damaged at the elbow flexion of the wrist, can still occur. So if the patient has ulnar nerve damage at the elbow, flexion of the wrist can still occur due to intact median nerve. So here the patient can do flexion not because of ulnar, but because of
median.
median nerve. Okay, but will be accompanied by abduction as flexor carpi ulnaris adducts the hand. Okay, wrist flexion will be unaffected when the ulnar nerve is damaged at the wrist. Sensory function. When damaged at elbow, all three cutaneous branches will be affected. Okay, so elbow here proximal. If you will injure the elbow, it means all branches will be affected. And there will be complete sensory loss in areas innervated by ulnar nerve. So if all three branches of ulnar damage, it's elbow or wrist? Elbow. When damage at the wrist, the two branches that arise in the forearm can be spared. So as we discussed here, we have two branches proximal and one branch is distal. If the patient has injury to three branches, so the injury is proximal. If the patient has only one injury, so it's distal. Okay?
Yes.
Yeah. So damage to the ulnar nerve at either elbow or wrist results in characteristic claw hand. So any patient has claw hand, until now you don't know it's proximal or distal. You don't know the injury here at elbow or at wrist, because both of them damage to ulnar nerve at either the elbow or wrist results in characteristic claw hand. With hyperextension of metacarpophalangeal joints, flexion of distal and proximal interphalangeal joints of little and ring fingers. When the ulnar nerve has been damaged at the elbow proximal, will be less clawing of the little and ring fingers, and there will also be loss of flexor digitorum profundus to this finger. So the differentiation here, it will be less clawing in the elbow. So what is this sign?
Claw hand.
Yeah. So the ulnar nerve innervates the following hand muscles: palmar interossei, dorsal interossei, medial two lumbricals, abductor digitorum, and others will be covered by median. So lateral two lumbricals are innervated by medial nerve, will not be affected by ulnar nerve lesions. Okay. So these are the muscles covered by ulnar. We are talking about lumbricals and abductor digitorum, this one, and also palmar interossei and the dorsal interossei. The ulnar nerve lesion can be tested for by using Fromen's sign. It can be a question. So be familiar with the test and with the sign. This is tested for by placing a piece of paper between the patient's thumb and the index finger. The tester then attempts to pull the paper out of the patient's pinched grip. In the case of an ulnar nerve palsy, the patient will have difficulty maintaining the grip and will compensate by flexing flexor pollicis longus of the thumb to maintain grip pressure. So this is the sign. Okay. The test, you will put the paper. It's called the Fromen test. The sign, it will be flexing flexor pollicis longus of the thumb. The patient interphalangeal joint of the thumb will flex, like this one. Which one is the sign, guys? Right or left?
Left.
Okay. So the one flexed. So this is how to differentiate between ulnar nerve injury if at elbow or at wrist. I will mention that quickly and you can review again when you are listening to the video. So motor loss, sensory loss, and deformity. So regarding motor loss, if you find in the scenario wrist deflection accompanied by abduction, so it's at elbow. Okay. Loss of all intrinsic muscles of hand except lateral two lumbricals, loss of lateral half of flexor digitorum profundus, loss of flexor carpal. So this at elbow. They can ask you, give you options. So ulnar nerve injury at elbow, number two, ulnar nerve injury at wrist, or median nerve, or radial nerve, and so on. So you can choose. Ulnar nerve at wrist, it will be normal wrist deflection. Loss of all intrinsic muscles of the hand except lateral two lumbrical, flexor digitorum profundus, flexor carpal ulnaris, both intact. Sensory, so loss of innervation to the anterior posterior surface of the medial 1.5 fingers and its associated palm and dorsal hand area. What about wrist? Loss of innervation, the palmar surface of the medial 1.5 fingers, palmar and dorsal cutaneous branch may be spared. Hand deformity, claw, hand deformity. We said at elbow, it will be less clawing of little and ring finger due to loss of flexor digitorum profundus. But at wrist, so claw hand deformity, more clawing of little and ring finger due to intact flexor digitorum profundus. Median nerve, so think about carpal tunnel syndrome. This one may be non-traumatic entrapment neuropathy of the median nerve, causes weakness paresthesia in the distribution of median nerve. The muscles innervated by the median nerve can be remembered using LOAF, L-O-A-F. So the median nerve can cover or supply lateral two lumbricals, opponent's pollices, abductor pollices, flexor pollices, brevis. It's unlikely to ask you in the exam about this anatomy, but be familiar with that. So median nerve here, the median nerve originates from lateral and medial cords of brachial plexus, has contribution from ventral roots of C5 up to C7, so lateral cord, C8, T1, medial cord. So median nerve from medial cord and lateral cord. It has both motor and sensor function. So motor function innervates flexor muscles in the anterior compartment of forearm, except the flexor carpal ulnaris and the part of flexor digitorum profundus, as we said, innervated by ulnar nerve. Also innervates the senar muscles and the lateral two lumbrical. So if you understand the ulnar, you will understand the median, because both of them can supply the opposite. Sensory function, it gives rise to palmar cutaneous branch, which innervate lateral part of the palm. So we said median for lateral and ulnar for medial. And the digital cutaneous branch, which innervate lateral 3.5 fingers on the palmar surface of the hand. The median nerve gives rise to two major branches in the forearm. So we are talking about proximal, anterior interosseous nerve, palmar cutaneous branch. So anterior interosseous nerve supplies flexor pollicis longus, ornator quadratus, and the lateral half of flexor digitorum profundus. Palmar cutaneous branch provides sensory innervation to the skin of the radial palm. So what about damage of median nerve? Damage to median nerve at the elbow and wrist can be distinguished because of these two branches. The same idea as ulnar, with injury at the elbow affecting these branches, but injury at the wrist is sparing them. So injury distal, it will spare them. Injury proximal, it will injure them. It should be noted that the palmar cutaneous branch travels superficial to the flexor retinaculum and therefore remains functioning in carpal tunnel syndrome. So here, how to differentiate between median nerve injury at elbow or at wrist. So motor loss at proximal, so weak wrist flexion and abduction, loss of thumb abduction and opposition, loss of flexion of index and middle finger. What about wrist? Loss of thumb abduction and opposition, wrist and finger flexion intact due to intact anterior interosseous nerve. Anterior interosseous nerve at elbow or at wrist?
Elbow.
elbow.
Okay. Sensor loss. So if median nerve injury at elbow, so lateral 3.5 fingers and the nail beds, lateral side of palm. At wrist, lateral 3.5 fingers and the nail beds, lateral side of palm, but can be preserved depending upon palmar cutaneous branch. Hand deformity. So you will find, if injury at elbow, you will find ulnar deviation of wrist, thinner wasting. Okay, so median nerve at rest, thinner wasting, no ulnar deviation. So if you find in the scenario ulnar deviation, this at elbow or at wrist?
Elbow.
elbow.
No ulnar deviation, it means at rest. And this because intact anterior osseous nerve. So this one, median nerve damage at the elbow. So verbal benediction. In contrast to ulnar claw, this one opposite. It is only apparent if the patient is asked to make a fist. So what is the difference between ulnar claw and the medial claw? Anyone can give idea?
Fist. Make a fist.
Yes. So in ulnar, the patient has claw without asking. Okay. But in median, he has no claw. But once you ask him to make a fist, it will be like that. Okay, guys? I think it's clear now. So when asked to make a fist, the patient will be able to flex the little and ring fingers, which is performed by the medial half of flexor digitorum profundus and the ulnar two lumbricals, innervated by ulnar nerve. So the patient can use the ulnar nerve intact, but the medial nerve, it's not intact. The patient will not be able to flex the index, middle finger, due to loss of anterior interosseous nerve. So this one will be anterior interosseous, so it will be elbow or wrist? Elbow. Okay. Therefore, when the patient attempts to make a fist, claw shape will occur, where the little and ring fingers are flexed and the index middle fingers are extended. We finished ulnar, we finished the median, and then radial. Again, ulnar and the median, they are palmar or dorsal? Palmar. Radial, it's dorsal, so posterior. We are talking about posterior. Ulnar and the median, it's anterior. Radial, it's posterior. So think about posterior interosseous nerve, okay? So this one branch from radial. What about anterior interosseous nerve? Branch of?
Median.
Median. Okay. After emerging above the elbow between brachioradialis and brachialis, the radial nerve divides into superficial radial nerve and the posterior interosseous nerve, where at the level of lateral epicondyle. Posterior interosseous nerve then passes through supinator muscle from anterior to the posterior surface of the forearm. So it means from anterior to posterior surface. In 30% of people, it passes through fibrotendinous structure below supinator muscle, arcade of Rose. Posterior interosseous nerve supplies all extrinsic wrist extensors except extensor carpi radialis longus. So causes of damage to posterior interosseous nerve Maybe the patient has fracture. Why we are discussing this? If you find, for example, in the exam, Monteja fracture, and they ask you what is the most likely injury, so you can choose posterior interosseous nerve.
Medium nerve.
You can choose radial nerve. Okay, so be familiar with Monteja fracture, radiocapitellar joint synovitis, tumors, entrapment with arcade froze. Injury to posterior interosseous nerve can also be easily distinguished from injury to the radial nerve further up the arm, the spiral groove, because there will be no sensor involved, no wrist drop due to preservation of extensor carpi radialis longus. So think about wrist drop in the scenario, think about sensor involvement in the scenario. The anterior interosseous nerve is a branch of median nerve. Largely motor nerve supplies flexor pollicis longus, lateral half of flexor posturum profundus, and the pronator quadratus. Damage to anterior interosseous nerve results in weakness and difficulty moving the index middle finger. So here, be familiar with posterior interosseous nerve and anterior interosseous nerve. Okay. Radial nerve injuries commonly associated with fractures of humerus. So it can be a question. The common cause of radial nerve palsy, external compression or trauma to the radial nerve as it transfers the spiral groove in the mid-humerus. Causes of damage to the radial nerve in the spiral groove, trauma, compression, iatrogenic. So they can give you scenarios, the patient Saturday night palsy. So the patient was in duty, maybe doctor or anyone sitting on chair, and he's doing compression on his arm. So after that, he has radial nerve injury. Injury to radial nerve within spinal groove results in extensor weakness of the wrist and metacarpophalangeal joints. Elbow extension is spared as the branch to the triceps and conus originate before the spiral groove. There will be sensory loss over the dorsal aspect of forearm from below the elbow extending to first dorsal interosseous. Injury of the radial nerve in the axilla can be distinguished from injury in the spinal groove, as it will also cause weakness of elbow extension and sensory loss of distribution of more proximal cutaneous branches. Posterior interosseous branch of radial nerve may also be damaged in the forearm, either by injury to the radial head or by becoming entrapped in the supinator muscle under the arcade of froze. This can also be easily distinguished from injury in the spiral groove because there will be no sensory involvement and there is no wrist drop, as we discussed earlier. So we still have herpes palsy and clumps palsy. So C5, C6, upper motor, and upper roots, and C8, T1, it's lower roots. So herpes palsy paralysis of the arm caused by injury to the upper roots of brachial plexus. The most involved root is C5, but in some cases, C6. So if they ask you what is the most common root, C5. The most common cause is traction on the arm during difficult childbirth, so common in childbirth. It can also occur in adults secondary to shoulder trauma. Clinically, the arm will hang at the side with elbow extended and the forearm pronated. That's why it's called waiter's tip sign. So elbow extended, forearm pronated. On examination, loss of shoulder abduction, so deltoid supraspinatus, responsible for that. Shoulder external rotation, so infraspinatus. Elbow flexion, so biceps and brachialis. Edge palsy can be contrasted with Columbus palsy, the opposite, which affect the lower rods of brachial plexus, C8 and T1. Presence with claw hand also. So this one was claw hand, paralysis of intrinsic hand muscle, and sensory loss along the ulnar side of forearm and hand. If T1 is affected, so you will find Horner syndrome. So this one, Ehr's palsy, like waiting tip sign. And the opposite is Columbus palsy. This one will be paralysis of the arm caused by injury to the lower roots of brachial plexus. Most involved is C8. C8. So what is the most involved in Ehr's palsy?
C5.
C5.
And in Columbus?
C8.
The most common cause is traction on the arm in an abducted position during difficult childbirth as well. Can also occur in adults due to apical lung carcinoma, Pancoast syndrome. That's why Pancoast syndrome, it can cause also Horner syndrome. Clinically presence with claw hand deformity and sensory loss along the ulnar side of forearm. And again, if T1 is affected, Horner syndrome. Subarachnoid hemorrhage. So we are familiar with the layers, so no need to waste the time. The meninges are 3 layers of protective tissue that involve the brain and spinal cord. They act together with CSF to protect central nervous system structures from mechanical damage and provide supportive network of cerebral and cranial vasculature. 3 layers, dura mater, the outermost, arachnoid mater, the middle layer, and pia mater, the innermost layer. 3 types of hemorrhage that involve the meninges. So extradural hemorrhage. Be familiar with subarachnoid hemorrhage, how to diagnose through CT, epidural and subdural. Search in Google about subdural and extradural and subarachnoid hemorrhage and check the CT scan and be familiar with different CT scan images. So extradural means epidural hemorrhage, blood gathers between dura mater and the skull. Subdural hemorrhage, blood between dura mater and the arachnoid mater. Subarachnoid hemorrhage, blood in the subarachnoid space between arachnoid mater and the pia mater. Subarachnoid hemorrhage, it can be traumatic and non-traumatic. So traumatic here, it will be in the scenario RTA. But if they mention the patient has sudden onset severe headache and thunderclap headache, so think about spontaneous bleeding in subarachnoid space. Age group in the scenario, 35 up to 65 years. 80% of subarachnoid hemorrhage are caused by rupture of aneurysm. So the most likely, peri or subcircular aneurysm. So it's an arteriovenous malformation. Perianeurysm associated with polycystic kidney. Maybe they will mention in the scenario the patient has polycystic kidneys, or Ehlers-Danlos syndrome, or coarctation of aorta. Risk factors, so smoking, hypertension, bleeding disorders, alcohol misuse, mycotic aneurysm, family history. Symptoms, sudden devastating occipital headache, worst headache of my life, in the scenario like that, followed by vomiting, collapse, seizures, common, any of them. Signs, neck stiffness. So neck stiffness here because irritation of the membrane, meningism. Positive Kernig sign, focal neurological abnormalities. Fundoscopy, it can reveal subhyaloid retinal hemorrhages. All proven cases of subarachnoid should be referred to neurosurgeon immediately. Focal neurological signs may be present, may suggest the possible site of aneurysm. According to the focal neurological signs, it can give you an idea about the site of the aneurysm. Common site of aneurysm, bifurcation of middle cerebral artery, it can be a question. Junction of anterior communicating cerebral artery, junction of posterior communicating artery with internal carotid artery, complete or partial palsy, third cranial nerve palsy. So this one suggests rupture of posterior communicating artery aneurysm. Hypertension is risk factor, but marked rise in blood pressure may occur as a reflex following hemorrhage. So maybe the blood pressure here is the reason for subarachnoid hemorrhage, or maybe as a reflex after hemorrhage. Investigations, so CT head scan, and if normal, what you will do? Lumbar puncture, 12 hours after onset of headache. So you will search for what in lumbar puncture?
RBCs. Blood.
So
Xanthochromes?
what is the test?
Xanthochromes. Xanthochromia.
Yeah, xanthochromia. Complications, so maybe stroke, ischemic or hemorrhagic. Ischemic stroke is due to cerebral vasospasm secondary to subarachnoid hemorrhage. Patients are treated with cerebral selective calcium channel blocker, so you can use nimodipine to prevent this complication. So again, subarachnoid hemorrhage, it can cause a stroke, whatever ischemia, or hemorrhage. Can cause cerebral vascular spasm. Okay, so as a reflex, a spasm will happen, and because of a spasm, it can cause ischemia. So if you find an option, calcium channel blocker, choose. If you find nimodipine, choose. Stroke TIA. So this is the cerebrum, cerebellum, midbrain, bones, medulla. So bones here, it's anterior or posterior?
Anterior.
Anterior.
And medulla?
Posterior.
Anterior.
So cerebellum posterior, medulla posterior, and bones here anterior. Okay. So if you check here midline, so this one anterior, this one posterior, it will help us in syndromes. So stroke TIA, as we said, it's ocular or neurological eye or brain symptoms. If more than 24 hours, it's stroke. If transient and less than 24 hours, it's TIA. So cerebrum, we are talking about anterior cerebral artery, middle cerebral artery, posterior cerebral artery. Okay, cerebrum. So the arteries covering the cerebrum. Okay, so anterior, middle, posterior cerebral artery. What about cerebellum? Okay, so anterior inferior cerebellar artery, posterior inferior cerebellar artery. Okay, so inferior, anterior, or posterior. So if inferior, anterior cover or supply,
Bones.
if inferior, posterior cover,
Middle.
okay. Okay, so both of them inferior. One inferior anterior and one inferior posterior. So this one, if infarction, study anterior cerebral artery infarction middle cerebral artery infarction, posterior cerebral artery infarction. And the study also anterior inferior cerebellar artery infarction. It's called lateral pontine syndrome. And posterior inferior cerebellar artery, so lateral medullary syndrome. So this one pontine, this one medullary. Okay. We will discuss about them now. So recognition of stroke in the emergency room, ROSESCO, how to understand this patient has high risk or not. Ask, has there been loss of consciousness or syncope? If yes, -1. Has there been seizure activity? If yes, -1. New acute onset of asymmetrical facial weakness, +1. Asymmetric arm weakness, +1. Asymmetric leg weakness, +1. Speech disturbance, +1. Visual field deficit, +1. So you think about face, arm, leg, motor, then speech, then eye. Also be familiar with ABCD2 score. So the nice recommendation for the management of patients with suspected TIA, here they are managing suspected TIA. They did not mention score. They are not mentioning score now. So you will give aspirin 300 milligram daily unless contraindicated to people who have had suspected TIA immediately. Refer immediately for specialist assessment to be seen within 2 hours of the onset of symptoms. Don't use a scoring system. They did not mention a scoring system. So just to be familiar with the ABCD2 score, but they did not mention about this score in the management to assess the risk of subsequent stroke or to inform urgency of referral for people who have had suspected or confirmed TIA. So it means don't depend on this score. Okay. Offer secondary prevention in addition to aspirin as soon as possible after diagnosis of TIA is confirmed. The nice recommendation for imaging for suspected TIA, don't offer CT brain to people with suspected TIA unless there is clinical suspicion of alternative diagnosis. So it's not routine. Any patient with TIA, what is the initial management, guys?
Aspirin. 300 mg.
Aspirin and referral.
Yes, aspirin and refer immediately for specialist assessment. Okay, to be seen within 2 hours of onset of symptoms. Don't use a score. Don't use CT brain until suspicion of alternative diagnosis. After specialist assessment in TIA clinic, consider MRI, including diffusion with and the blood sensitive squeeze, to determine the territory of ischemia or to detect hemorrhages or alternative pathologies. If an MRI is done, perform it on the same day as the assessment. Carotid imaging, everyone with TIA who after a specialist assessment is considered as a candidate for carotid endarterectomy should have urgent carotid imaging. So, as I said earlier, be familiar with the infarction. Infarction of anterior cerebral artery, middle cerebral artery, posterior cerebral artery. These arteries covered what? Cerebrum or cerebellum?
Cerebrum.
Cerebrum. Okay. And we will discuss also regarding inferior, anterior, and the inferior what?
Posterior.
Anterior for what?
Cerebellum.
Bones. One cerebellum.
Bones. And the posterior for?
Medulla.
Medulla.
Excellent. So anterior cerebral artery, we are talking about contralateral motor weakness. If they mention in the scenario, the patient has a contralateral motor weakness, for example, leg or shoulder, more than arm, hand, or face. So upper, here, leg or shoulder, more than arm, hand, face. Okay. Minimal contralateral sensory loss, dysarthria, aphasia, left limb apraxia, urinary incontinence. This very important, specific here. Once you see urinary incontinence, think about anterior cerebral artery. Behavioral and personality changes. Also, this one specific. Think about anterior cerebral artery. So, what about middle cerebral artery? Contralateral hemiparesis. So, what is the difference between hemiparesis and weakness? Hemiparesis different than hemiparesis. So hemiparesis, it's sensation,
sensory
Sensation.
weakness or
not
paralysis.
only weakness, motor.
Contralateral hemisensory loss, expressive or receptive dysphasia, and the dominant hemisphere. Okay, so the patient has problem in speech. Contralateral neglect, non-dominant hemisphere. Okay, so think about middle cerebral artery. So dysphasia, specific here. Posterior cerebral artery, contralateral hemanopia, specific. Once you see hemanopia, so think about posterior cerebral artery. Quadrantic visual field defects, so again, vision. Contralateral thalamic syndrome, so think about posterior. Again, we finished already anterior, middle, and posterior cerebral artery. We still have inferior anterior and inferior posterior for bones and the medulla. So we will start by lateral pontine syndrome. So it's an anterior inferior cerebellar artery. So this one, obstruction of long circumferential branches of basilar artery, because basilar artery is here, results in lateral pontine syndrome. So how to diagnose that in the scenario? Patient has ataxia, ipsilateral loss of pain, temperature sense on the face because of trigeminal, ipsilateral paralysis of upper and lower face, vertigo, nystagmus, tinnitus, deafness, and vomiting, contralateral sensory loss to the body, so damage to spinothalamic nerve. If you find any feature of that, think about lateral pontine syndrome. And this can ask you what is the artery involved. So anterior, inferior cerebellar artery. And here, lateral medullary. So we are talking about medulla. This one, posterior, inferior cerebellar artery. And the syndrome is called Wallenberg syndrome. Occlusion of posterior inferior cerebellar artery. Lateral medullary syndrome, same. So characterized by contralateral loss of pain, temperature sense on the body, ipsilateral loss of pain, temperature sense of the face, vertigo, nystagmus, tinnitus, stiffness, and vomiting, Horner syndrome. So Horner syndrome here, it's specific for lateral medullary syndrome. So the area, so anterior cerebral artery, it's anterior, middle cerebral artery, this one, middle, and posterior cerebral artery, this one, posterior, and anterior choroidal artery. Regarding dysphasia, so think about two areas, Broca and vernix. So vernix here, receptive aphasia, it means receiving the patient receptive, and Broca's here, it's expressive aphasia. So this one anterior, this one posterior. So vernix area in the temporal lobe of the dominant cerebral hemisphere, in the posterior part of the superior temporal gyrus. So the patient here can understand written and spoken language. So if you write to the patient, he can understand. If you speak to the patient, he can understand. Otherwise, he has problem in this area. Damage to vernix area, it means receptive aphasia. It means he cannot receive what is written, he cannot receive what is spoken. Okay. What about Broca's area? In the frontal lobe and dominant cerebral hemisphere, in the posterior part of the inferior frontal gyrus. Control of the motor function of speech. So what is responsible for controlling the motor function? Like larynx, mouth, tongue, and soft palate. So damage to Broca's area, it will cause expressive aphasia. It means the patient can understand what is written, what is spoken, but he cannot express because of problem in larynx or mouth or tongue or soft palate. So he cannot express, he cannot send. So it's expressive aphasia. So if the patient has whatever stroke or TIA, and you decide you will give alteplase. So alteplase is recommended for thrombolysis for treatment of acute ischemic stroke in adults. Treatment is started as soon as possible within 4.5 hours. It can be a question, onset of stroke symptoms. Intracranial hemorrhage has been excluded by appropriate imaging techniques. The initial dose of alteplase can be a question, 0.9 milligram per kilogram, 0.9 milligram per kilogram, up to maximum of 90 milligram given IV over 60 minutes. The initial 10% of dose is to be IV injection and the remainder by IV infusion. So if the patient 70 kilogram, you will use
0.9 milligram per kilogram. So it will be
70. So if the patient has 100 kilogram, so maximum 90 milligram. Okay, remember that. The initial dose 10% will be bolus and then infusion. If the patient weighs 70, so 63 milligram. And if the patient, for example, 120 kilogram, so the maximum 90. Don't use 120 kilogram. Okay. So what about contraindication? Severe hypertension, more than 180 by 20. So it's a contraindication to thrombolysis. 180 by 120. Blood pressure should be reduced to below that level within the thrombolysis window, within 4.5 hours, in order to proceed. So when to give, within 4.5 hours. When to control blood pressure, within 4.5 hours to proceed with alteplase. If you want to decrease blood pressure, labetalol, 10 milligram IV over 1 to 2 minutes. Nitrate infusion, isocate, can be used as alternative in patients with contraindication to the use of beta blocker. So if labetalol contraindicated, what you will use? Nitrate infusion. If you find in the scenario the patient has asthma, heart block, or cardiac failure, what you will use?
Nitrate infusion.
Okay. Tetanus. So here they can ask you about tetanus infection itself. So tetanus prone wounds and high risk tetanus prone wounds. So like puncture type injuries, wounds containing foreign bodies, compound fractures, wounds or burns with systemic sepsis, certain animal bites and scratches, high-risk tetanus wound, heavy contamination with soil or manure, wounds or burns that show extensive vitalized tissue, wounds or burns that require surgical intervention that is delayed for more than 6 hours. So if the patient has tetanus already, we are talking about tetanus infection. So how to understand this diagnosis? They mention in the scenario, for example, the patient has injury 1 week ago or something like that, and now he has trismus, dysphagia, rigid abdomen. In severe cases, maybe they will mention in the scenario respiratory difficulties, okay, autonomic instability. So think about tetanus infection. Consciousness here is not affected. So if you find the patient is conscious, it doesn't mean it's not tetanus. So don't depend on that. Localized tetanus or cephalic tetanus. The patient has rigidity, spasm confined to the area around the site. So if the patient has a wound in the shoulder, for example, and he has rigid spasm in the shoulder, so it's called localized tetanus. Okay, so localized symptoms can continue for weeks or may develop into generalized tetanus. Cephalic tetanus, localized tetanus after head or neck injury, involving primary musculature supplied by cranial nerves. What about management? So wound debridement, antimicrobials against anaerobes. So you can give IV benzyl penicillin, metronidazole. Remember that, it can be a question. IV immunoglobulin based on weight. So if less than 50 kilogram, you can use 5,000 international units. If more than 50 kilogram, you can use 10,000 international units. What about vaccination? Vaccination with tetanus toxoid following recovery. Supportive care. So if the patient has muscle spasm, you can use benzodiazepine. Also treatment of autonomic dysfunction, maintenance of ventilation if the patient has a respiratory problem, nursing in a quiet room. So be familiar with the indications for immunization. Okay. So here, tetanus prone, high risk tetanus prone, and the later treatment. You can review this schedule when you are listening to the recording. Tumors involving the brain and the spinal cord, the cerebellum. So the function, it plays an important role in the following function: maintenance of balance and posture, cerebellum, maintenance of balance and posture, coordination of voluntary movements, motor learning, cognitive function. So if the patient has tumor and he has these symptoms, so he has cerebellar tumor. Okay. Vernix encephalopathy we discussed already before in previous chapter, so no need to waste the time. Okay, what is the single most likely diagnosis, guys?
Episodic tension
Type of headache.
last option.
Episodic tension type headache.
Okay, excellent.
Number 5.
What is the single most likely diagnosis?
Idiopathic intracranial hypertension.
Last option.
Last option.
Okay, idiopathic intracranial hypertension. Because of bilateral papilloedema.
And overweight. 6 cranial nerve.
So, what is the single most likely diagnosis?
Intracranial hypertension.
Option B.
B.
So the same diagnosis because papillary edema, and also body mass index 33. And again, 6 cranial nerve palsy. Following is this
Option 3.
Papillary edema, option C.
okay. Single clinical feature, cluster headache.
Option E.
lateral midriff B.
C.
Ipsilateral lacrimation.
Ipsilateral rhinorrhea.
Last.
No,
Lacrim.
this might be
B.
option
this might be
Midriff.
rhinorrhea,
Option B.
B.
injection.
Option B.
B
Midriff.
should be meiosis.
Mydriasis. Inconsistent.
Option B.
Okay. So the most important ipsilateral. Not an effective treatment for headache.
Oral codeine.
Option B.
Number 2.
Okay, excellent. Single most likely diagnosis.
Cluster headache.
Cluster headache because water, right eye also waters when it's painful.
Okay, excellent. Single most appropriate treatment.
Sumatriptan.
High dose steroid.
High dose prednisolone.
Diagnosis.
Arthritis.
Giant cell
Giant
arthritis.
cell arthritis.
Yes, excellent. Why?
The age.
74-year-old
74 years
and
old.
usually have pain when
I
combined
think
Fracture
claudication.
of neck.
scalp tenderness,
Temporal area.
and age.
Temporal area.
Single most likely.
Migraine.
Excellent. Most likely diagnosis.
Temporal arthritis.
Temporal
Arthritis.
Excellent. Type of seizure has she experienced 7 years?
Petit mal.
Number B.
B.
Okay,
C.
excellent. So brief episode and last a few seconds. Type of seizure.
Generalized tonic-clonic. Last option, yeah.
Yes, generalized tonic-clonic.
According to the current ABLS guidelines,
IV access in place. Lorazepam.
Lorazepam. Lorazepam 2
Lorazepam
mg.
2 mg.
2 milligram.
IV
2
access.
milligram.
Second option.
Second option,
20
20
mg per kg.
Over 20 minutes.
Okay. Buccal midazolam.
Second option.
0.5.
0.5.
Diazepam.
0.5 also.
Third option.
0.5.
IV access in place.
2.5 lorazepam.
Lorazepam.
First option.
Okay.
0.1.
IV
0.1.
0.1.
0.1.
Okay. ABLS algorithm.
20 mg per
Number
kg.
3.
Third
Number
option.
Number 3, yeah.
Okay. Excellent. So doses of IV lorazepam.
Phenytoin infusion. Phenytoin.
History of
Phenobarbital.
Phenobarbital.
B.
Option 2.
excellent.
Phenobarbital.
History of epilepsy, it means he is using phenytoin.
Phenytoin, yes.
She continued to have seizure for the next 10 minutes.
Propofol.
Propofol.
First.
Phenytoin.
Okay. So after lorazepam, phenytoin.
Yes.
Yes.
Okay. Drug treatment should be administered.
Glucose.
Phenytoin.
Same question.
Yeah. Following drugs would be most appropriate.
Failed response.
20 minutes.
IV لازم.
Propofol bolus. Rapid sequence injection.
Adult algorithm, right?
Yes.
Okay.
Drugs would be most appropriate to administer next. He said
IV lorazepam.
IV lorazepam.
Lorazepam.
Last one.
Intravenous glucose.
intravenous glucose. Why?
1.1.
Okay, he said 36. Having a seizure lasted for 35 minutes. Continue to have tonic-clonic seizure, non-epileptic. That's why she's taking lamotrigine for seizure prevention. Single dose of rectal diazepam. Okay, by the paramedics on route approximately 10 minutes. Observation, heart rate, and blood pressure, oxygen saturation, temperature, and the blood sugar. Did they mention blood sugar in the start?
No.
Okay, what is the first action here?
2 minutes for ABCD.
Rectal diazepam given.
Yeah, why he managed epilepsy first before glucose?
Because glucose in D.
Non-case of
That's why.
In D.
So was here it's in D, disability.
D. Yes.
Yeah. So he gave already management for epilepsy.
For seizure.
After that, who can manage the glucose. Okay. And also the glucose here,
Thiopentane.
you will manage by intravenous, right?
Yes.
Yes.
Because he said intravenous access
there
in
is
cycle.
IV access.
It means oxygen first. After that, you can insert the IV access. You can extract the blood for hematology, biochemistry, blood gas, blood culture, and the blood sugar.
Yes.
Okay. Yeah. Which of the following drugs?
Thiopental.
Thiopentane sodium bolus.
Most appropriate to administer next? Single dose of
Single
rectal
dose.
diazepam.
Repeat the dose. أيوه.
Intravenous thiamine.
Why thiamine?
Alcohol abuse.
Alcohol abuse.
Okay, because of alcohol abuse. Single statement, benzodiazepine.
Number 1.
No.
Lorazepam can be.
Option C.
Rectal route.
Single most likely diagnosis. 54. Gradual worsening in weakness in his left leg. Denies any history of speech, back pain, problems with bowel or bladder function.
Motor neuron disease. So A.
Excellent. Okay. Following this treatment is indicated in this patient.
Antitoxin.
Toxin.
Botulism.
Number B.
Botulism.
D.
Okay. So what is the diagnosis?
Botulism.
Botulism.
So the patient 27, double vision, problem in swallowing, no previous medical history. Examination, bilateral ptosis, dilated pupils, dry mouth, find the swallowing water difficult. His deltoid power 4.5, his upper and lower power 5.5.
Understanding the botulism.
Cannot elicit any sensory deficit. His observations are recorded, so it's botulism. Which of the following most likely diagnosis?
Botulism.
The same
B.
scenario. Botulism. Okay. With cavernous sinus thrombosis, clinical picture is usually dominated by
Ocular
which?
findings.
Ocular finding.
Okay, ocular finding. What is the most appropriate next management?
Anticoagulation with heparin.
Anticoagulation with heparin.
Aspirin. Heparin.
Okay.
Heparin first, then
Most likely
antiplatelets.
Cavernous sinus thrombus.
Complaint of sinus.
OCP, taking OCP.
Examination.
Cavernous sinus thrombosis, option B.
B.
Okay. So 30 years, 2-day history of worsening the headache, double vision. No past medical history, but did complain sinusitis. Only prescribed medication combined to oral contraceptive. It's a risk factor. Proptosis, left eye turned inwards. So features of cavernous sinus. Risk of developing lung.
6%.
6%.
Yes.
6%.
Okay. So is this one complex or not?
Yes, complex.
Brief self-limiting seizure at home. So I think it's not.
Simple. Yes.
Not complex.
Simple seizure.
6%.
10%.
10%.
6%.
10.
10%.
Single most likely diagnosis. 28.
Guillain-Barré syndrome.
Last one.
TB syndrome.
Guillain-Barré syndrome. Okay. Because he said here severe diarrheal illness 2 weeks ago. So after GIT symptoms here.
Spreading proximal.
Most likely causative organism. Single most likely diagnosis.
TB syndrome.
Guillain-Barré.
Guillain-Barré.
Okay. They mention here Campylobacter jejuni. Antibiotic.
Benzyl penicillin.
Benzyl penicillin.
Chloramphenicol.
Chloramphenicol.
Yes. Anaphylaxis to cephalosporin.
Yep.
Yes, because we mentioned here anaphylaxis. According to the current NICE guidelines, which of the following feature most suggestive of diagnosis?
First option.
Neck stiffness.
Neck stiffness.
Focal seizure.
Cephalitis.
Yes, because focal seizure should be with
Viral.
Cephalitis.
Viral infection.
encephalitis. Single most likely diagnosis.
Option
Group
E.
B.
Group B.
Group B.
B, yes. Single most appropriate next step.
Chloramphenicol.
Okay. Current NICE guidelines, most suggestive of diagnosis, encephalitis.
Last one.
Last
Focal
one.
neurological.
Neurological signs.
According to the current NICE guidelines, most suggestive.
Capillary
Capillary
Increase it.
Excellent.
Shock.
Single most appropriate choice, chemoprophylaxis.
Rifampicin 600 mg per hour.
Ceftriaxone.
Ceftriaxone.
Yes, pregnant.
Yes, because the patient
22 weeks.
most suggestive.
Last option.
Increased level of consciousness.
These levels of function.
Most appropriate initial management.
Ceftriaxone.
2 gram IV.
Okay. Single most likely diagnosis.
Subarachnoid hemorrhage.
Meningococcal septicemia.
Number 4.
Number 4.
Okay.
Meningococcal septicemia.
So neck stiffness and the photophobia.
Yeah.
Tickler rush.
Not consistent with good prognosis.
Not consistent.
Old age.
Older age.
Old age at time.
Older age of time.
Older
diagnosis.
age at the time of diagnosis.
Okay. So he's talking about what?
I see. Yeah.
Multiple.
Multiple
Sclerosis.
single most likely diagnosis.
Multiple sclerosis.
Multiple sclerosis.
Multiple sclerosis.
Fatigue, enlargement.
Okay. So patient 24, painless diplopia, last day, getting concerned about 6 months ago. She also remembered having 4 nights where she lost sensation in her right arm. So which type of multiple sclerosis?
Amyotrophic.
Aggressive, I think. It was
Progressive.
6 months.
Progressive.
Single pattern of multiple sclerosis he is suffering.
Primary
Primary
progressive.
progressive.
Okay. Parkinson's disease occurs primary as a result of loss of
Midbrain.
Midbrain.
So
Midbrain.
استنى anagram midbrain.
Which of the following clinical feature is most likely to also be present?
Cogwheel
Cogwheel.
rigidity.
Cogwheel rigidity.
Okay. Clinical features most likely to be present.
Dementia.
Hypokinesia.
Hypokinesia.
Most likely to be associated with Parkinson's disease.
Depression.
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 Most likely diagnosis.
Parkinson's disease.
Parkinson.
Parkinson's. Single medication.
Obanaldopa.
Oh, Benaldo.
Oh,
Number 2.
Single most likely diagnosis.
mental function.
Dementia with
Dementia was
Lewy.
Lewy bodies.
Dementia with Lewy body.
Okay. Which of the following clinical feature is generally only seen in the later stages?
Postural
Postural instability.
Postural instability.
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 Okay. Most likely to be associated with Parkinson's disease.
Dementia.
Lewy bodies.
Dementia. Single most likely diagnosis.
Memory decline. Dementia.
Corticobasal disease.
Rapid decline in heart function.
Clinical feature generally only seen in later stages.
Cognitive impairment.
Cognitive impairment.
Okay. Loss of the pulmonary
Substantia nigra.
Substantia
Third
nigra.
option.
Single most likely diagnosis.
Aggressive
Supranuclear palsy.
supranuclear.
Supranuclear palsy.
Okay. Single most likely diagnosis.
Supranuclear palsy.
Multiple system.
We mention here incontinent urine, high-pitched voice. Later stages.
Orthostatic hypotension.
Yes. Least likely to be affected. Ulnar nerve in the right arm.
Lateral to
Medial
lumbricus.
to lumbricus.
Lateral.
Nerve lesion occurred in this case.
Median.
Ulnar.
Nerve. Ulnar nerve of the elbow.
At
Ulnar
elbow.
at wrist.
Option.
Option.
2.
At wrist.
Option.
At elbow.
Wrist flexion.
Least likely to be affected. carpal tunnel syndrome.
Median.
Digitimini, abductor digitim.
Abductor digital.
Yeah, because this one is ulnar.
Ulnar.
Nerve lesion.
Ulnar. Interosseous.
Radial.
Muscle.
He said dorsal.
This is dorsal.
Ulnar nerve.
Allah now.
Ulnar nerve.
Okay.
Foreign sign.
Most likely to be affected.
Medial to lumbrical.
Ulnar nerve.
Ulnar.
Medial to lumbricals.
Median.
Okay. Lesion has occurred.
Radial now.
Median. Anterior. And
Posterior.
Pain.
Because radial deviation.
radial deviation.
Which nerve lesion has occurred in this case?
Ulnar nerve at the elbow.
Okay.
Wrist.
Okay.
Single most likely diagnosis.
Earth pulse.
Pulse.
Palsy.
Earth palsy.
Single most likely diagnosis.
Side of the
Hand.
Clumpy.
Clumpy.
Okay. Most likely be affected.
First option.
T8.
CAT.
T8 and T1.
Yes, because Horner syndrome.
Corners.
Likely
Ulnar.
damage.
Ulnar
Ulnar
nerve.
nerve. Option E.
Lesion occurred.
Median now at wrist.
Most likely affected.
5.
T5.
5.
Which
Medial
nerve?
nerve at the
Median now at the wrist.
Pulpal benediction.
Elbow.
Okay. Lesion has occurred in this case.
median nerve at the elbow.
Ulnar, because where is the fist type?
Make a fist.
Make a fist, so median.
Median nerve.
Single most likely diagnosis.
Subarachnoid hemorrhage.
Sudden onset severe occipital hemorrhage.
Say subarachnoid hemorrhage.
Most appropriate initial investigation.
CT head scan.
CT head scan.
Okay. Following spaces will blood have gathered.
Arachnoid
Third
ampia.
option.
Arachnoid
Arachnoid
and
and
3.
option
Arachnoid and 5.
Yeah.
First option. Polycystic kidney.
Okay. Most likely mechanism.
Cerebral vasospasm. SH.
Okay. So what does it mean hypodensity?
Ischemia.
Ischemia. Because of subarachnoid hemorrhage. Because of spasm. Single most likely diagnosis.
Lateral medullary
There
syndrome.
Okay. Because of Horner syndrome.
Horner.
Healthy
63.
place, 70 kilogram.
63.
Okay. Because 0.9 milligram.
Yes.
Imaging procedure. TIA clinic.
Carotid.
Carotid imaging.
Okay. Blood vessel.
Middle.
Middle cerebral artery.
Middle cerebral artery.
Most appropriate next step.
Lobate renal.
Lobate.
200.
Because the patient has
200 by 1.
Hypertension.
not to correct within
Beta blocker IV.
4.5 hours.
He has 1 hour, right? So you still have time, right? You are within the window now.
Window period.
Blood vessel.
Receptive this way, yeah. Middle.
Medial.
Median.
Cerebral artery.
Middle. Single most likely diagnosis.
Wallenberg syndrome.
Wallenberg syndrome. Blood vessel.
Anterior cerebral artery.
Anterior cerebral artery.
Urine
Incontinence of
incontinence.
urine.
Middle cerebral artery.
Middle cerebral artery.
Single most likely diagnosis.
Lateral pontine syndrome.
Okay. Altiplase 120
90.
kilogram.
90.
90.
90.
Yes.
Blood vessel.
Posterior.
Posterior. Posterior cerebral
Posterior
artery.
cerebral artery.
Vision. Vernix area.
Receptive.
Receptive aphasia.
Broca's area.
Expressive.
Expressive.
4.5.
4.5.
4.5.
Altar place.
Alteplase.
Appropriate next step.
First option should be given.
Aspirin and refer within 24 hours.
300.
And referred.
Introduction.
Facial expression.
Facial expression.
Frontal.
Spontaneous facial.
Okay.
Parental form.
Dog bite.
Dog bite.
Dog bites.
Dog bite.
Fasted on one. Iris.
Second option.
Extensive
Devitalized seizure.
Prophylaxis.
Okay.
Tetanus vaccine alone.
Vaccine alone.
What treatment should this patient receive?
Vaccine and immunoglobulin.
Okay.
Okay.
Should this patient receive?
Option D.
250.
Option D.
Okay. Following treatment should this patient receive with regard to tetanus prophylaxis?
No tetanus
Option.
vaccine.
First option.
No
need for
First option.
Full 5 doses.
Thank you, guys.